actually been more recently than I have. Okay. Why did that go back into that? Let's try this again. All right. Welcome, you guys. Are we gonna be expecting other people to come? Yeah. Okay. Hopefully they won't. Oh, I can keep this off. I think we're on. So, all right. So I mean, this, these boot camp lectures, we try to make them really fun and interesting. But the truth is, there's a certain amount of just I tried to, in the past, I put in a lot of kind of the evidence and stuff, and I always go over. I always go on. In fact, I'll probably still go on. And so I'm trying to a little bit just. I tried to pare it down a little bit. Hopefully, I'll just get going. We'll see. Okay, so basically, we always have a case, and this is kind of typical at the VA. It's usually a man, but nevertheless, a lot of comorbidities because smoking always affects more than one organ. Like the 75-year-old with many comorbidities. She has known COPD, and she presents for care. She's had a recent admission. That's how someone referred her to the clinic, and she actually needed oxygen on discharge. She's on Advair, Spiriva, ProAir, and albuterol nebulizers. She loves her nebulizer. She's kind of iffy about taking the rest. And then she has severe obstruction on her PFTs for 25% FEV1, air trapping, also noted, and a low DLCO. She's still short of breath in spite of the oxygen and all of her inhalers, and she didn't bring her oxygen today. She doesn't look too happy right there. Let's get rid of this. So that's the end of the case, and there's nothing. And we just start churning out the facts now. The thing about COPD is that when we see at the VA, you would think it's 75% of the population, but actually, it's although it's common, it's not as common as it is at the VA. There's lots of different prevalence estimates. More or less, it's probably 10 to 20% prevalence. Part of that is we don't have a lot of patients who have COPD don't get spirometry, and so we probably are underestimating the prevalence of COPD. NHANES spirometry, NHANES nutrition and health, National Health and Nutrition Examination Survey is a huge effort that's been going on since the 1970s in the United States, where they do this 15-page survey, and then they have since 2000 they've done a number of spirometry surveys, and since 2008 they've done every single year with post-bronchodilator spirometry as well. This is a huge database, and some of this data comes from there. That's where a lot of our predictive values come from, although there's other attempts to do that as well. But basically, spirometry is the Achilles heel of diagnosing COPD. It's the only way to truly diagnose it, but since so few people get it, including in teens, we probably are underestimating even in our studies that are specifically designed to diagnose COPD. And that's because there's different ways of interpreting spirometry. Although usually all kind of evens out or comes out in the wash or whatever. But if you don't use post-bronchodilator flows, you tend to decrease prevalence, for example, and there's probably some over-diagnosis in elderly people. So this is the problem. We have a good test to diagnose it, but the interpretation can fail us. Worldwide prevalence estimates, kind of the same process, same Achilles heel. There are areas of the world where we don't even really do a lot of studying, particularly some of the middle economies, Africa, South of Asia, some parts of Central America. And so there's a lot of estimates that are changing, but probably 14% in men, and then 7%, 7.6% in women. Some people say as low as 5%. That's almost certainly an underestimate. It's around. And so the natural history of COPD, and this is why it can be a little bit tricky. We have, this is actually old, this is an interpretation of an old study, but basically this is an estimate of only one risk factor, smoking. But nevertheless, starting at age 25, they estimate that your FEV1 actually increases up to age 25. And then if you never smoke, and there's a lot of people out there who are actually not susceptible to smoke at all, you just aren't susceptible even if you did smoke, you tend to have a basic decline in your FEV1. But if you smoke, obviously it declines much faster. Say you quit smoking at age 45, oh here we have 45, you basically still decline but at a slower rate, and it's more or less parallel, maybe a little slightly less parallel than this other one. If you continue to smoke, you go down pretty fast if you're susceptible. Genetics are a big deal with COPD. We're still figuring that out. Once this is the level at which you start having symptoms, symptoms, and then this is when you start needing oxygen usually, and people will sometimes stop at this level, and they get a little benefit from smoking, but they still have a lot of disability. So basically, on this graph, we're always trying to get people to smoke, or quit smoking, not smoke, quit smoking, because we see that if we can manage to get people to smoke at an early age, sometimes for a number of years, they can actually avoid symptoms and compared to the smoking. And then even if they're at disability and they quit, we'll sometimes see fewer symptoms and a delay of death, COPD-related deaths. Now, this is my interpretation, which is that there is sometimes a subset of COPD that is the frequent exacerbator phenotype, and this patient will decline even if they're smoking or not smoking, and they exacerbate, their FEV1 drops, and then when they recover, they never quite come up to the baseline, and it kind of goes down from there. My lines are not that great. And this is something we know that exacerbations screw with COPDers. And so a lot of our management is based on avoiding exacerbations. This is actually something that has been brought home. This is based on a journal article in New England Journal 2017 by Lang. And basically what it shows, of course, it shows from birth the FEV1 actually increases, but there are a subset of patients both in this both who have an external trigger for COPD, which is usually smoking, and then those who don't have any external trigger, who actually have small lungs. And that could be related to developmental issues, early people who are born premature, for example, and they actually will develop COPD without any external factors. And that's the small lungs, but no COPD. And then I don't know what TR2 stands for, I can't remember. But then there are a number of patients who have small lungs leading to COPD. And so these are patients who never had any external factor in these data spaces. And then there are, of course, those who have a decrease in FEV1. So there actually are people who, for various developmental reasons, rather not smoking, but childhood exposures, but also underlying issues based on their frame or physiology, their frame or genetics, that actually develop COPD without any external factors at all. We used to always think COPD was pretty much an environmental disease. It's not. This shows it's not necessarily true. So this is some of the pathophysiology of COPD. This is a more recent version. It's a little impressionistic from this days. It's a little impressionistic version of the pathophysiology of COPD. Basically, pollutants and smoke. Obviously, this completely ignores some of the developmental issues. But we have here pollutants and smoke coming into the lungs. Some go directly into the bloodstream, actually directly affecting the hemoglobin. And actually can cause, there's actually some data showing that there may be a hypercoagulability issue. I can't remember which one of these is supposed to be the antioxidants, but it basically, pollutants and smoke increase oxidants both in your alveolus and in your blood, which basically releases various cytokines and inflammatory factors. The enzyme that we seem to discuss the most are the metalloproteases. that cause direct damage to the structures of the alveolus and decrease the function both of the cells. And then the long-term effects, of course, is decrease in elastin, decrease in the recoil of the lung, which then leads us to an emphysematous phenotype, or it can increase the inflammatory relation. Let's see. Actually, I'm going to move on to the next slide. This one. It decreases and the inflammation actually increases production of mucus, decreases ciliary clearance, and then that can lead to a bronchitic phenotype. More on that a little bit later. This is the inflammome, and this is a little bit of an older slide from 2012, but I actually haven't found anything better than this. So basically what we see here is that a non-smoker has smaller amounts of systemic inflammatory factors, and this is white blood cells. These are supposed to be biomarkers of COPD, but it's actually biomarkers of inflammation. C-reactive protein, TNF-alpha, IL-8, IL-6, fibrinogen. But then if you're a smoker, an active smoker, this group was 100% current smokers. You have more white blood cells. You can think about, I think neither of you, Damaris was in clinic with me last week. Yesterday in clinic, we had all these patients who were smoking and had tons of mucus. And based on this, you can say, that mucus, which is, especially if it's purulent, has a high amount of white blood cells in it, probably related to smoking, going from 5% increase in this biomarker to 31%. Same with TNF-alpha, and then IL-8 here. Unfortunately, we tell them to quit smoking, and we do have a decrease in the white blood cells. Now, obviously, these are averages. This is not every single patient. But we do have a decrease in the white blood cells. But we have fibrinogen. We have other inflammatory markers that still are persistent or actually increase. Fibrinogen, IL-6 increases, C-reactive protein increases, TNF-alpha decreases. And so what we find, based on this, we know that you can quit smoking, but you probably still have inflammatory-driven progression of your disease, which is an issue. There are phenotypes in COPD that seem to be the direct result of this. The emphysematous phenotype. This is these, of course, the patients don't fit neatly into these categories. This is one phenotype, but basically what we see is that the alveoli are basically the pulmonary structures that are exposed to smoke on a regular basis, and even though some of those that are not, like the blood vessels, are not exposed to the smoke, but they are exposed to the inflammatory reactors, they basically develop the elastin essentially degrades, and the way I think about it, it's like a rubber band that's been left out too long. And so as the patient inhales, that recoil that's supposed to help them exhale nicely is inhibited by the fact that the elastin doesn't recoil. You still have recoil from other structures like the cartilage and the recoil from basically the chest wall that's facing your stomach, but the recoil is minimal. Add to that the airways are collapsing because they also have their elastin destroyed, and they will flop as the flow of the air goes through. That is indicative one mechanism of the obstruction of COPD. Now another phenotype, which is the bronchitis predominant phenotype, is not necessarily related to destruction of the elastin and recoil of the structures, but it's the inflammatory component of that causes increased mucus production. And these are the goblet cell, for example. But you also have the epithelium that is inflamed and swollen. You'll have, of course, here is this is an indicative of a involuntary muscle that is constricted. We're having a bronchospasm, which causes an issue. But it's the only thing that's really modifiable here. Well, you can try to modify the mucus, but the main thing is the bronchodilation. And this may be what we call, again, its most extreme form, the frequent exacerbator phenotype. By the way, these are the names I made up. These aren't official names. This is what I call them in my brain. And this is a continuum. There are plenty of patients who have both emphysema and bronchitis. And you don't necessarily always see from looking at a patient what phenotype they have, and you learn it over years and multiple sets of PFTs. Okay, so diagnosis. Sometimes you feel like when a patient comes in, you're like giving them a fortune. They're like the diagnosis cookie. Anyway, so this is from 2020. The 2021 gold has a slightly nicer looking graph. But basically, I think the way you diagnose COPD is that you need to have the three legs of the stool. You have to have symptoms. The symptoms are what usually trigger you to think about COPD in the first place. And then if you're a clinician, you're like, you say, oh, what is your risk factor for COPD? Sometimes it's smoking. We often forget about some of these other factors. We mentioned a little bit about the host factors. These could be developmental issues. Also, it can be alpha-1 antitrypsin. Never forget about that. And sometimes it's related to problems with the chest wall. And then occupation. Actually, in the 2021 COPD goal, they actually acknowledged the effect of warehouse workers. So all that paper that flies around and people who work in all these Amazon warehouses around here, that's actually considered to be respected. But the big one, of course, is tobacco. And the third leg of the stool has to be spirometry. If you only have these two and you forget this one, your stool's going to fall over, because sooner or later you're going to say, do they really have COPD? Maybe they have an infection. Maybe they have something else going on. So don't forget the other risk factors. Viruses and some gram-negative raw Pseudomonas, for example, are risk factors for COPD. Think of the inflammation that comes from a chronic Pseudomonas infection. Factors from this is actually in Guatemala. We'll see that the constant smoke without a chimney is also a factor in terms of level of COPD. Occupational issues, burnout, asthma, but of course the big one is cigarettes. As we know, and I think it's probably been hammered home to you for the last, I don't know, since you're in college, who knows. They have to have spirometry to get the true diagnosis of COPD. Sometimes there's a patient who will never be able to tolerate that spirometry, and that's just fact of life. But for the vast majority, we should be really trying to get that patient to get COPD, get spirometry for a true diagnosis. And then once you get the diagnosis, you tell the patient. And the thing is, though, and I think I mentioned this to you, Maris, this slide, and this is kind of this slide has been around since 2019. I mean, it doesn't explain it very well. So I had to feel like I had to walk through a little bit better. Once we get that third leg of the stool, the spirometry, and we'll sit there, we'll even assess very carefully the grade of COPD, this gold 1, 2, 3, 4. The next step is they kind of throw away the spirometry. Like, okay, they have COPD, we know it's bad. And we care a little bit about the stratification if we're going to send them to surgery, or if we're going to refer them for maybe a valve, endobronchial valve. But the truth is, what we really care about is this part, because this is how we determine what we're going to do for the patient. Outside of surgery, outside of some of these other interventions for COPD, the main thing is when we're going to think about bronchodilators or how we're going to try to manage their symptoms. We think more about symptoms and how many times they've been exacerbated in the last year. So this is the old way, and the thing is, here we have up here old. This is from like, I don't know when this is, from maybe 2005. It's old, but everything was based on whether they were at risk, mild, moderate, severe, and then this is ATS kind of, and then they converted it to gold, which is moderate, severe, and very severe. And everything was about the FEV1. But the truth is that wasn't a very patient-centered way of managing a patient. And you can have a patient who is very severe COPD but never had any mucus, and actually was kind of doing okay. Do you really want to send that patient for roflumilast and give them roflumilast and make them nauseated all the time when they're not really having any symptoms? Of course, you have them on triple therapy. Is that going to help them? Well, it doesn't. Unfortunately, we know that inhalers don't really modify the disease very much, so maybe you don't want to give them all those side effects. So basically, the trend since 2013 has been focused less on spirometry and focused more on symptoms and exacerbations. And we come up with this little grading system, and so when you present to me or present to Dr. Foles, I don't know if he's in the clinic still, but you present to any of your attendings, you want to think about how many exacerbations has the patient had in the last year and what are their symptoms. Now, at the VA, we tend to just care about dyspnea, but that's not always the case. We actually want to think about other things. And there are ways of assessing symptoms that actually are maybe a little bit more inclusive than just dyspnea. And I think I have here, I can't remember, do I have it? Oh, Dr. Mandel saying we have patients in the office. Okay, all right, so I just want to mention real quick, and I thought I had it up here, I don't have my little preview. There is something called the CAP questionnaire, which we tend to use here at UH a little bit more, and it assesses not just dyspnea, it assesses mucus production, some of the quality of life things, like people who are afraid to leave their house because they're afraid they're going to have symptoms and either be embarrassed or not be able to get help. Patients who can't sleep because of COPD. So it actually is 10 questions that have a little bit more inclusive range of symptoms that we have to worry about. But once you determined that they have, for example, a CAT greater than 10, the maximum CAT is 20, or MMRC greater than 2, and that is basically the patient who, when they're walking with their friends, have to slow down. The VA vet who says, I have to take my time when I walk. Those are the patients that you think, okay, there are symptoms, they're probably in this area. If they don't have symptoms, they're in the A and C qualities. You can have no symptoms, but have a lot of admissions. And those patients, the group C, they're the patients who, I don't know why they're going to the ER all the time. It's what's scaring them to go. But usually they go to the ER and they break their ribs or they've broken their foot or something. And then someone listens to them on the ER and says, it doesn't sound so good. And they treat them for an exacerbation. Typically though, these patients usually kind of are hard to find. Everybody else we see all the time. So this is kind of a very broad brush way of thinking about starting inhalers in these patients based on symptoms and exacerbations. This one is the one we see at the VA the most. They have symptoms, but they haven't quite managed to the point where they're going to the ER all the time. Or sometimes they're going to, the symptoms are, they have like a little bit of shortness of breath, but no mucus, and they just kind of get around on their own because they're VA vets and they're never going to go get asked for help. These patients might actually be minimized. You never quite know. But in this one, we usually just start some sort of bronchodilator. This is the ones that don't have symptoms and don't exacerbate. But if the group B, we frequently, and based on the most recent data as of 2016, we tend to want to start them just on bronchodilators. And if we try, unless there are good reasons, that sometimes we do start them on an inhaled corticosteroid first with a bronchodilator, but they need some sort of bronchodilator. If they're over here in the group that has an exacerbation but without any sort of symptoms, you usually can start them on a long-acting muscarinic antagonist. And then what this means is this is progression. They have further exacerbations. You can start them either on a LABA/LAMA or ICS. And the trend here, as you see, is that this is the exacerbation part of the 2x2. If you have a lot of exacerbations, they seem to think about, the gold guidelines kind of want you to think about inhaled corticosteroids. And we'll go through the data real quick about inhaled corticosteroids. If they don't have a lot of exacerbations, you kind of can skip down here with just the bronchodilators. Symptoms, well, we still do inhaled corticosteroids with symptoms. But as long as if you avoid the exacerbations, you can kind of get away with some bronchodilators. So I think everybody knows all this terminology. I just want to make sure LABA/LAMA. These are some of the brand names that are associated with these. These are actually, since there's no brand, it's just, nobody does just LABA. And there's actually some interesting story behind that someday I'll tell you. But that's salmeterol, formoterol, antimuscarinic. So this would be I forgot, I didn't put, so this would be Spiriva. Or I think it's, I can't remember what the other ones are, the other brand names, I should know. But LAVA ICS is usually the Advair Symbicort groups, Anora, Bavespi, Stiolto, or the LAVA-LAMAs. So just these, this is basically a quick little interpretation, a way to interpret all the LAVA-LAMA things. Oh, well, out of order, here's the CAT questionnaire. Great, okay. So this is what I was talking about. You can't read it because it's out. Here's the MMRC. You know, I discovered that at some places they actually they have it that breathless. I only get breathless and strenuous exercise is 1, and I don't know why. That some people have 1 for this, but I think this, I don't know why. But I always start with I only get breathless with strenuous exercise to be a 0. That's my take. So I mentioned a little bit that the first easy steps are the bronchodilators, and I'm going to just keep moving on about this. Oh, it didn't come out. This is the part I gave you a little teaser about. I can talk a little bit about inhaled corticosteroids. Corticosteroids in COPD are used only in with the patients with the most symptoms and the most infrequent exacerbation. This is the so-called group D. And there's a lot of history behind that, and I have one lecture that I've given a couple times where I go through all the history of all the corticosteroid data. I'm not going to do that to you today, but sometimes, you know, there's a long and storied history about starting steroids early in COPD, and unfortunately, if you guys will see when you get a referral for COPD. 75% of the chance that 75% of the time that patient is already been started on corticosteroid because it's easy. The primary care doc sometimes hasn't sent them for spirometry, or they sent them for spirometry, but they didn't really know how to interpret that well. Or maybe they interpreted it, but it was relatively normal. The patient's very symptomatic, and we just throw them on that. So that happens a lot. These are our common corticosteroids. The problem is pneumonia. And since 2008, the Stone Age, 2007, sorry, when this is a kind of a little bit of this is what counts as controversy in the COPD world. They're trying to figure out what inhalers provide benefit. At this time, the big holy grail was trying to determine which inhaler improved mortality in COPD, and not a lot, not very few of them do. But as they tried to evaluate, the patient outcomes, they found out that in this, all trial arms with inhaled corticosteroid had increased incidence of pneumonia. So you have to be aware that when you start your patient on inhaled corticosteroids, particularly if it's a phenotype that is a lot of mucus, very frequent exacerbations, which are the ones that most want to start inhaled corticosteroids on, they tend to be the frailer patients, more elderly patients. Those are the ones that are more likely to get pneumonia. Now that turns out to be about 70% with LAVA ICS. Actually, I'm sorry. These are the outcomes: reduced COPD exacerbations, et cetera, et cetera. When you look at this tends to be about 15%, and I don't know how I can put that up here. We actually this has been followed by a number of investigators, even most recently, this study. This is why we try to start our patients on bronchodilators first. It's only a meta-analysis of all these are huge trials. They're like 10,000 patients. Impact is 10,000 patients. There's another one that we'll talk about in a little bit called, oh man, I can't remember. You'll see. Anyways, there's like 10,000 patients each. And so this is a pretty robust meta-analysis of these trials, and they all share the same structure. They're all RCTs. It favors LAVA-LAMA combination starting when you start your patients on all the inhalers. And that's mainly because of the risk of pneumonia. This is relatively recent, 2018. There's data even that's come out since in 2020 that confirms this. And so if your patient doesn't have a lot of mucus, if your patient doesn't have, try to start them just on LAVA-LAMA first. Fiolto at the VA, a neuro, there's another Bavesti elsewhere. Now, there is going to be a time though, even if you want to only start your patients on lateral, there's going to be a time where you okay, I got to go to the next step. And that next step is almost always steroids, inhaled corticosteroids. Is it going to help? And there aren't a lot of biomarkers in COPD patients that will tell you if it's going to help or not. So what you need to do, and this is pretty primitive. Basically, you look for some of these indicators of patient-centered outcomes, history of hospitalizations for exacerbations of COPD. So not just exacerbations, but hospitalizations with exacerbations. Or if they're very frequent exacerbations, and this is the one that is kind of a biomarker, not really, but we still look at it. Eosinophils, blood eosinophils greater than 300 cells. That's not the percentage, and basically you have to convert. You have to look at the absolute number of eosinophils and convert it, which basically a couple zeros to know what is exactly the equivalent of 300 cells. Or if they've had asthma in the past, and you'd be surprised how many patients will tell you, "Oh, I had asthma as a kid," and you have to ask. Now, the ones where we run into trouble are these ones where they have a few blood eosinophils occasionally. And if you look at, you guys may have seen, I always pull up the worksheet in the VA to see that their whole history of eosinophils. And a lot of times you'll see these times when they're 7% eosinophils, which is the equivalent in that patient of about 300 cells, but then they're down to normal and they're not exacerbated. So, maybe there was something going on in their lives at the time, but it's tricky because some patients have eosinophils some days, sometimes they don't have eosinophils. So this is where you're just like, maybe it'll help. And then these are the patients where you really want to avoid them. Do they have this history of MAC, more rarely TB? If they have no eosinophils, repeated pneumonia events. And so these are the patients who, they may have a little bit of reflux. They may even have a lot of aspiration. They may be frail in other ways. You really want to think really hard before you start them on corticosteroids. But sometimes you do. Sometimes you have to. And I'll talk about that in a little bit, why we consider that. There might be some funny things you've noticed in outcomes of COPD trials. I mentioned that in 2007, 2008, when the TORCH trial was published, they were thinking about mortality all the time. Well, we discovered that there's not a lot of benefit for inhalers, not a lot of mortality benefit for inhalers. So we always have timed exacerbation, symptoms, lung function, health status, but no single inhaler or inhaler class has shown a mortality benefit. Not even a disease-modifying benefit. However, combination therapy is more effective. And so what we found, and this may be why you want to think about inhalers, even in your most frail patients, you may have to think about an inhaled corticosteroids, is that inhaled corticosteroids and LABA improves lung function, health status, reduces exacerbation. Regular treatment, of course, you have to think about this, increases pneumonia risk and severe disease. And the magnitude of inhaled corticosteroid benefit is lessened in current and heavy smokers. So if you have a patient, which is like 25% of our VA patients, who is still smoking and sometimes even smoking heavily, you can't really you don't really know that the inhaled corticosteroid is going to help a ton. However, our one tiny mortality benefit with inhalers comes with triple therapy. And so you're going to have to sit there and weigh the consequences. Inhale, maybe I have to move them from the LABA-LAMA combination to triple therapy because we do have these two trials, the ETHOS trial and the IMPACT trial, both published in 2020, which show that there is a teeny, tiny, significant mortality benefit when you start triple therapy in COPD patients. They have to be severe and they have to be a frequent exacerbated. And so that's why there are times, even in the most frail patients, we'll choose triple therapy. And we did that even before this data came out, because sometimes you're just desperate. Okay, just realize there are other anti-inflammatory medications. PDE4 inhibitors, roflumilast, macrolides. You always have been around me starting people on azithromycin. Mucolytics, specifically N-acetylcysteine. And this is no one has really, there are 2 little tiny trials, like 30 patients each, but have never been followed up because the big trials, the 10,000 patient trials, are all sponsored by pharmaceutical companies. N-acetylcysteine is basically free. No one is, it's generic. No one's ever going to do a big trial or have a big trial on it. But I do give it to the patient. Sometimes it has a huge pill, unfortunately. Now, it seems like a lot of our COPD patients are on leukotriene modifiers, glucose. We don't know that helps at all. I actually been taking it off because it actually is now a black box warning about depression.
The idea, like, again, for those kind of allergic eosinophilic patients. Kind of,
yeah, but the people who are starting it, which is pretty much the primary care doctors, they're not checking eosinophils on.
Just like, okay.
So I think they're just, sometimes you just throw the patients in the
Sure.
just trying to help them. But we don't know that there's a benefit. I'm going to speed up because we're running out of time. But just a little bit about Daliresp. The biggest, it decreases exacerbations. So you really have to have a frequent exacerbation. They are a lot of mucus. Usually they tend to be the kind of bloater phenotype. So it inhibits neutrophilic inflammation. So it can be particularly helpful in the neutrophilic predominant mucus producers. But it's expensive at the beginning. It's usually not common to get though. Nausea and tachycardia. And the nausea is the big one. If you start at a half dose, and then after a week, go to full dose. Macrolides. This is actually, it was about 2000 and I think it was 2008, 2009, this data started coming out. Actually, it was 2010 when they announced it at ATS. I remember that directly. We were all excited. But it really didn't, we still do it, but after we started on the papers. And you want to make sure you check QT and hearing. I used to do 3 times a week, but then it's just easier to do 250 milligrams. So I still check, I monitor QT. N-acetylcysteine, I mentioned this, big pills, hard to swallow. You have to be very clear when you're ordering it, especially in patients, that this is not nebulized. A lot of people, it's Mucomist, this is Mucomist, the brand name is Mucomist, and if it's nebulized, there's no proven benefit. The benefit is in PO, 600 milligrams twice a day. N-acetylcysteine, but man, it's hard for them to take that big pill. It's a big pill. But I have a few patients who do it. Don't do that. Theophylline does not reduce COPD exacerbations. Very narrow therapeutic window. A lot of side effects. And then a lot of these patients, when they have an exacerbation, you put them on azithromycin, all of a sudden their LFTs are down. So I tend to avoid it. Sometimes I come to a patient, I inherit a patient who's on theophylline. Actually, I've done that here mainly because it's a cheap medication and so many patients really can't afford their copays. I'll keep them on it in that context most of the time. If they have any other option, I'll avoid it. Vasodilators. This is usually sildenafil. There was a cardiologist in the VA who put every COPD patient on sildenafil for a while there, so they adhered a lot of them. It does not improve outcomes at all. It may actually worsen oxygenation from like a high outflow heart failure. It really is not a good idea to have in COPD patients. Antitussives, you have your patients who love their guafenicin, they love their Mucinex. Like, I need my Mucinex, but they don't really have an proven benefit. Of course, you want to always screen for alpha-1 antitrypsin deficiency because augmentation therapy will actually slow the rate of emphysema. The goals. So I'm almost out of time. I am out of time. So just be aware that these are the goals. Mortality decrease. These are the big ones that decrease mortality. Smoking cessation, influenza vaccine, oxygen in patients with severe resting arterial hypoxemia, and lung volume reduction surgery. There may be a little bit of, we're seeing a little signal of pulmonary rehab improving mortality, but it's only in the case association, not so much causation. And the last one is, of course, I had to bring up, don't forget triple therapy and severe COPD. Quality of life, the biggest quality of life is pulmonary rehab. That's really going to improve the quality of life for patients. It's hard, you know, VA, if they smoke, you can send them, there's a distance issue. You really have to pull teeth sometimes to get your patients to go. But most of them, once they do go, maybe they're just trying to make you feel better, but once they go, they actually enjoy it. Social component improved, and it helps with their deconditioning. They learn a little bit about their disease. So it does help. Try to get it less than 4 weeks out from exacerbation. It'll actually prevent exacerbations in that situation, mainly from the education component. But even you can do it if it's more than 4 weeks out, because there is improvement in quality of life, exercise tolerance, and dyspnea. All right, we are out. You guys will hear a lot more about this over the course of your fellowship. And you guys know how to find me, except you can't avoid me. So ask me questions, ask me questions, ask me questions. I know you will. You're actually, you all have been pretty good about asking questions. Oh, that's why you are where you are, internet. You guys want. These are all good things. You guys pay attention to Connect. If you like COPD, Connect is a mover and shaker in the COPD world. On Fridays, she's been working really hard to get kind of a combo clinic where we do a lot of teaching. We're gonna do COPD action plans. We're gonna do inhaler technique. It's gonna be the big hurdle for doing this has been me and my schedule, because I have not been keeping up my end of the bargain. And I need to make sure that everybody gets credit. That's the thing. Everybody gets credit for working in this little clinic, but we're gonna try to have kind of we call it a multiple shared medical visit clinic where we have people in groups and they come in, and it's kind of like pulmonary rehab without treadmills. And we're going to try to do that. So pay attention to that. She's going places. And that's it. I'm out of time. Any questions online? I don't even know if you can hear me. Let's see.
I can hear you loud and clear. No questions on our end.
I don't even know if they are on Zoom.
Thanks, Dr. McKell.
Okay, they were on Zoom. All right, I'm sorry. You guys are gonna have to find me later on and ask questions, okay? Because I can't hear everything you're saying. Anything in the chat? No. I think it is early in the morning. You probably just signed in and got sleep. So I'm gonna leave meeting. Ask me questions. You guys know how to find me.